You are listening to the Horse Radio Network, part of the Equine Network family.
Welcome to this episode of the Disease Du Jour podcast. I'm your host, Carly Sisson, and in this episode, I spoke to Dr. Kaycie Hatcher about upper airway disorders. This episode of Disease Du Jour is brought to you by Equithrive. Born and raised in Panama City, Florida, Dr. Hatcher is a true Floridian native. Growing up in the Panhandle, she had the unique pleasure of riding everything under the sun. Beginning her equine career at a young age on hunter horses, she slowly found her way to the Western performance horse world and settled into a niche of barrel horses before attending college. During this evolution, she also found a secondary love in production animal medicine, and she became heavily involved in the cattle industry. Collegiately, she attended the University of Florida for both her undergraduate and veterinary schooling. Given her background, Dr. Hatcher has a special interest in performance horses. Furthermore, she has a large professional interest in upper airways and gastrointestinal systems. Welcome, Dr. Hatcher.
Thanks for having me.
Thank you so much for being here. To get us started, what are some of the most common upper airway disorders that we see in horses, and what do we currently know about their underlying causes or risk factors?
So that is a massive question. And I think that the common things we see typically depends on kind of our subset of practice and our subset of horses that we generally have. So I am a general practitioner, but I do have a little special interest in performance horses. And I typically see a lot of Western performance horses in my region. I do have a decent number of higher end dressage and eventers as well, but the Western performance horses are really the ones that kind of hold the line for me in my practice. And so when we talk about common upper airway disorders, I think it's important to remember that there are pieces to this upper airway. And so when we talk about them, we kind of have to think about all sections of this upper airway and know that in each of these sections, you can have things that go wrong. So we call the upper airway essentially the extrathoracic airway, which is just fancy doctor words to say that that's the stuff that's outside of the chest and the body. If we were to kind of go from head to tail, you'd talk about things like the nostrils, the nasal passage, the pharynx, larynx, paranasal sinuses, guttural pouches, and the trachea as well, which actually, weirdly enough, happens to be my favorite area. One of my favorite diseases happens there. It's super weird, but whatever, that's a personal thing. For me specifically, when we start to kind of work our way through that from nose to tail, I think the most common thing that anyone sees, no matter your GP or not, if you're doing teeth in horses, you actually see a lot of tooth root abscesses. So old horses can totally develop tooth root abscesses that can actually lead to a sinusitis. And it's important to remember that in horses, primary sinusitis is actually a little less common, whereas a secondary sinusitis, so a sinusitis developed from a tooth root abscess, is like the leading cause of why you see that kind of thing. Some people will also have more masses. I live in a very strange region of Northwest Florida, so I actually get to see a lot of really strange and weird things. In my personal practice, I actually have a lot of weird upper airway masses, and that can include things like ethmoid hematomas, epidermal inclusion cysts, cancerous masses that develop inside of the sinuses or inside of, like the paranasal area and things of that nature. But the really kind of bread and butter probably of this talk are the things that actually are associated with the palate and with the larynx specifically. And so there are a massive amount of diseases, like in terms of numeric number, that can exist within that region. For me specifically, I tend to feel like I see a lot more palatal instability. So things like dorsal displacement of the soft palate, whether that's persistent or intermittent. And I also see things that are kind of wrong with the larynx. So like recurrent laryngeal paralysis. And I have actually had my own personal horses that were barrel horses that had recurrent laryngeal nerve neuropathy. And so that is something I think that kind of probably takes the upper line for us. But also, being that we live in Florida for our practice, we do tend to see a lot of inflammation just generalized to the actual upper airway, specifically like laryngeal edema. Sometimes we'll see cicatrix in this region because of chronic allergies. And so just upper inflammation to that palatal arching that can really cause some upper respiratory disorders. So I think those are probably the most common for us.
Yeah. Do you find that Western performance horses are more prone due just like to the work they do or the environment that they're training in?
That's a really interesting question. So there was a paper that came out from the University of Calgary in October of 2023 that actually did some massive research over like 270 horses, where they actually dynamically scoped barrel horses, specifically barrel horses, because the large majority of our respiratory research seems to be associated with other types of performance horses. Really, if we think about it, it's largely thoroughbreds, right? I'm not a Kentucky practice. I have worked on thoroughbreds in Ocala, but we don't really have them in our region. We have the barrel ponies. So if you think about the idea of a performance horse, you kind of think about a couple different sectors. And barrel horses are one that have been left off for a little while. Nowadays, we're starting to include them. And Calgary really did a fantastic job in October of 23 looking at that. And so what they actually found was that most of these horses seem to have issues that are occurring at low intensity or low speed rather than high speed or high intensity, which I think is kind of counterintuitive to what we traditionally expect or what we think about. And we actually think that the way that we frame them or shape them up, aka like putting them into flexion when they're at low speed environment, that actually is causing a massive pressure differential and causing flatal instabilities and actually causing airway instability, basically. And so I would say, I think it's less, there may be some element of environment that's associated with it. Obviously, being in a super dry, super allergic, dusty, horrific state like this one, we do see some element of environmental allergies that absolutely play into respiratory disorder in performance horses. But I do think that a large portion actually is the training and the way that we actually ask these horses to carry themselves, and whether or not, there was also a small study that actually happened, I think in 2015, looking at whether bit fit made a difference in horses for upper airway disorders. And what we found was it was way less about bit fit and way more about positioning of the rider and rein tension. And so when you start to cross the sectors between disciplines, you can kind of find these different airway disorders that kind of pop up when horses are placed into these dynamic flexion type situations. And so I think that's probably our primary concern when talking about whether or not it's more prevalent.
Yeah, that's interesting. This podcast is brought to you by Equithrive. Vitamin E is a critical antioxidant essential for horse health and performance. Yet many horses fall short due to limited pasture access or increased athletic demands. Equithrive Vitamin E pellets provide a natural, bioavailable source of vitamin E in a palatable pellet for consistent daily intake. This formulation is ideal for horses requiring targeted vitamin E supplementation to support neurologic health, muscle integrity, and exercise recovery. Equithrive Vitamin E pellets, dependable antioxidant delivery where it matters most. Use promo code Du Jour, that's DUJOUR, to get 20% off your first order, plus free shipping at equithrive.com. What are some clinical signs that would raise suspicion for an upper airway disorder for you?
So if we're talking about the common GP things, nasal discharge has to be your first and foremost, right? And especially if you have malodorous or super smelly nasal discharge, whether that's one-sided or both, that also is very helpful. As a general practitioner, you can obviously never forget about strangles. And so you always kind of need to do a really thorough time asking your client, for just a good history and getting a good signalment and kind of what's happened with his horse. So outside of the GP sector, outside of having nasal discharge that's either malodorous and snotty, essentially, or having bloody discharge or things of that nature, I think the most common thing that we get in terms of clinical signs are things actually like poor performance or respiratory noise, actually. And so it's really interesting when we start to actually dive into that respiratory noise aspect, because there are basically two types of respiratory noise that we talk about, stertor and stridor. And so one of them is associated with inspiratory and the other is associated with expiratory. And that can actually help line us up into a differential diagnosis or start driving us to the correct direction for where we might need to start looking. So I think for us, that's definitely what we traditionally see is poor performance. Oh, and the other one to not forget about, actually, is weird behavioral changes that are associated. So barrel horses are known for being kind of hot and kind of snotty. Vinters can be as well, right? The cross-country horse before he gets in the box. And so we do actually seem to see a behavioral change associated with these horses outside of their performance level, where they actually are increasingly more anxious to enter the box. They're increasingly more reluctant. And it's not necessarily because they're being blown up, as one would say in the common industry, and more that they actually are experiencing things that are happening while they're performing that's causing anxiety and giving them negative biofeedback.
Right. Yeah, that's a tricky one because that can happen for so many reasons, I imagine. And maybe for owners, an airway disorder wouldn't be top of mind when they're starting to have that anxiety going into the box, but that's a great point.
Yeah.
Walk us through how you start to build your differential diagnosis list and what sort of background information you like to collect from the owner when you go out to see the horse.
For sure. So I think, like I said, any clinician should start with signalment. And that basically means how old is it? What breed is it? What sex is it? And my initial follow-up question as soon as I get that information is, well, what do we do with this horse? And I don't accept that, oh, well, I event him. I'm like, oh, yeah, that's so cute. What do you actually do? What does work look like for this horse? And how often are we competing? Where are we competing? Things of that nature. I think one of the easiest things for us to miss, and the further that we get in our clinical practice and our history on our own selves as DVMs, is to get somewhat complacent in gathering those background pieces of information as to, what are you doing here? And how is this horse actually truly being worked? But outside of your signalment, outside of your really aggressive clinical history, I also think that it's incredibly important to have the owner describe specifically what they're seeing to you. Just while he's not performing well doesn't mean anything to me. It might trigger enough for you to show up at my doorstep, but that doesn't actually describe to me what you're seeing. In my region, I get a lot of owners that say, well, you probably think I'm crazy. And I'm like, yes, you're a horse person, so you are. However, please tell me what you have to say. And so I really try to hammer on them as to what are you actually seeing here and when are you seeing it? So is the upper respiratory noise happening when this horse is cantering? Is he cantering specifically to the left? Is he cantering on the buckle, or is he cantering actually in frame and inflection? What are you riding him in? What does your bit fit look like? Things of that nature. It's kind of really silly as well. But when they describe that a noise has happened for my performance horses, I will physically make them try to replicate the noise for me. I've definitely had some owners that were goose honking in the middle of a barn aisle with me to describe a cough. So things of that nature, I think, are incredibly important when you're starting to do the back work here to try to build your differential diagnosis. And like I said, when they describe a noise specifically with airway disorders, that can help you kind of lean yourself into, is this an inspiratory or is this an expiratory? And where would that potentially happen? And where would that line up? For me as well, for like the higher end performance horses, if it's happening under really specific sets of circumstances. So say it's a barrel horse that only does it when warming up within the first 10 minutes at a trot and a lope. I really, really, really want to see that actually. So I actually will make my owners ride for me a lot, which usually goes okay. Sometimes it gets a little bit hairy if the horse is feeling a little froggy. So things like that, I think, are really important on the backside, and they really kind of help you figure out what you might have. So you can't just take one section of it. The history will start you and will lead you into this particular thought of, okay, is this infectious? Is this inflammation? Is this congenital? Things of that nature. And then you can start to find your way into where you might need to be.
Then how do you start to narrow down the types of diagnostics and imaging that would be required, and when would you go to more advanced imaging?
So if we're specifically talking about the performance horse, it gets really easy to jump up to advanced imaging really fast. So plus, I'm a younger graduate. I'm a younger veterinarian, which means I was raised with the toys. Therefore, I love the toys. If I get to use them, I get really excited. But I do think that having your hands on and actually getting a really good physical exam are really important aspects of doing your legwork on the backside, if you will. So starting off with your examination, measuring whether or not you have symmetric airflow bilaterally is really important, which is kind of a silly thing to do. When you do that in goats, actually, you can do it with a glass slide. When you do it with horses, you got to use your hands. It's like an old school looking, anyways. But, using your physical exam is really important to do that, or to start to determine where you might be seeing your issues. And furthermore, to determine whether you're actually dealing with upper respiratory versus lower respiratory, because it can be easy for owners to also get misled by their own findings because everybody likes to Google. And that's totally reasonable, especially if you guys are in areas that are not served well or not served thoroughly, as in you just don't have enough equine vets. So I actually oftentimes in horses that are coming to me for these kind of things, I will do a rebreathing examination. So I'll basically put it back on their face and choke them out for a couple minutes until I actually get them to increase their lung volume enough that I can really appreciate that. If I get a cough, I'm evaluating that nasal discharge. You can pull for things if you think it's actually inside of the ribcage. You can pull for things like ultrasound pretty darn fast to see, whether or not you're dealing with like an pneumonia or whatnot. If you've determined that you are indeed in the upper respiratory tract, it gets pretty quick to want to either A, go to x-rays or radiographs, or B, go to endoscopy. And not everybody has endoscopy. A standing resting endoscopy as well is maybe not as effective or maybe not as informational as a dynamic endoscopy might be. So basically where we shove the endoscope, so the camera into the horse's nostrils and ask them to work at the same time. So if we're really truly locking into the fact that it might be performance inhibiting in the upper respiratory, a lot of times these horses actually have to get referred outwards. So my job really kind of as a first line responder is to determine whether or not, for one, is it something simple like a tooth root abscess that I need to take the tooth out of the head? That's pretty quick. Or am I dealing with something like this horse has intermittent dorsal displacement of the soft palate and needs to go see a surgeon and have a dynamic scope done? So starting with a really strong physical examination, absolutely critical. And then very quickly, usually you're jumping into things like radiographs and endoscopy.
Right. So once you've narrowed down your diagnosis through all of these different tools, how do you start to form a treatment plan for that patient? And when do you sort of lean more on medical and environmental management? When do you go towards surgical intervention?
So that is kind of where we have to think about our initial pathways, right? Whether it's that infectious, inflammation, congenital types of situations. And that's old school baby vet breakdown, right? But if I have something that is more inflammatory driven, so say that I have pharyngeal edema, so the portion of the airway that's just in front of the larynx is quite inflamed. And I think that it's potentially happening from environmental stimulants. I am absolutely going to try to medically manage them. Absolutely. If I can give them, steroids to try to decrease the inflammation there, or anti-inflammatories, decrease the inflammation, make environmental changes, because I think, hey, this horse is suspiciously allergic to peanuts. He's eating peanut hay and he puts his head in his peanut hay. And then all of a sudden now he's coughing as he's inhaling the dust. And that's not enough to really piss everything in the airway off, but it is enough to cause some pharyngeal edema. Then I'm going to try to medically manage these guys. If I'm suspicious that I have something like a recurrent laryngeal nerve paralysis or an RLN, I'm going to probably send that horse a whole lot faster for a surgical workup than I would for the horse that I might potentially be able to manage. And mostly just because as much as I would love to play superhero, I can't re-innervate anything or tie back one out here in the field. That is for the big guys down in Ocala to do. And so if I have something that might be infectious or might be inflammation, I'm more apt to try that. Now, the one area that I actually deviate away from being more apt to trying it is if I'm very suspicious that I have a horse that might have a guttural pouch mycosis or a guttural pouch empyema. Those are cases that I am not very excited to try. If owners require me to try a line of medical management, I might give it a rumble to throw some antifungals in there. But without a good medical team and without a hospital on board in case that goes sideways, aka the horse ruptures an artery and starts to bleed out and die, you run a pretty hard risk on those. So traditionally speaking, I tend to send my guttural pouch diseases, unless it strangles, of course. Then if it strangles, you obviously medicate. you do what you do on the farm. They don't leave anybody. But, if it's a guttural pouch disease, I tend to try to send those horses a lot faster than if it was just an inflammation type of situation.
Right. Unfortunately, you're in an area where you have good referral hospitals, but I imagine that can get a little bit tricky if you're maybe in a more rural area of the country.
I'm 4 hours away from every referral hospital. So when I send one, I have to have a darn good reason. Yeah. But the owners are pretty darn good. Usually if I say, hey, man, we need to do this, they're pretty quick to say, okay, let's do it. I had a case actually last fall. The horse presented with unilateral epistaxis, pretty small amounts, just kind of drops that his mom noticed in his feed pan. And I said, oh, I really don't like that. And at first, when I'd met the horse, they said, oh, he has recurrent allergies. So we started to treat him like he was an RAO horse or a recurrent airway obstruction horse. So he had allergies, basically. And lo and behold, after 2 days worth of her noticing some of that, I said, he's going to see the big guys. And we sent him to a tertiary referral center. They scoped him. He actually had a cancerous mass that was sitting inside of just at the edge of his ethmoids and right actually at that paranasals. So he unfortunately was euthanized. But had we have not seen that, there's a really real chance that he would have actually had a pretty massive catastrophic event without us noticing it. So if I see some weird stuff like that, they go. There's no waiting.
Yeah. So that case obviously didn't have a great prognosis, but what are, some other factors that might influence prognosis for some of these common conditions, ranging from the, less serious to the more serious conditions?
So the less serious stuff, say like an epidermal inclusion cyst, actually, I have a lot of those in this region. So if any of you listeners have a weird mass that exists in kind of the nostrils, that's probably what you're looking at. Those are some of my favorites. They're super fun to play with. You literally just pop some formalin in them and bombs away. They'll finally basically resolve on their own. You can also surgically excise those guys, but you need to do it completely because like any cyst, they will recur. Things like that, super simple, super fun. Prognosis is great, right? Recurrent alar folds or extra nostril folds, basically tack that bad boy up. Life is simple. Take it away. Life is simple. Everything goes well. Tooth root abscesses, pop a tooth out. Everything's kosher. But when you start to get to some more serious diagnoses, things like a horse that maybe has a vocal fold disorder that needs to be, surgically corrected, or a horse that has recurrent laryngeal nerve paralysis that needs to try to maybe be reinnervated or tied back or something of the nature, the prognosis, while good for survival, can be very dependent on the horse specifically. And so lots of surgeons have lots of opinions about whether or not things go super or things don't go super. And I think that is, while somewhat surgically dependent, I also do think that it is very dependent on the horse specifically. And there are some things that just the same as human surgeons can't tell you whether the prognosis for performance is going to be stellar. We can't necessarily predict them very well. I have had plenty of horses in this region that have had some form of surgery performed on their upper airway, whether that was larynx or pharynx, and they were fine, but they weren't any better. While I've also had plenty of horses that were great. So if I were to try to put a number on it, I would actually say probably 70% of them did quite well, but 30% of them were maybe the same actually and or worse. Okay. And so I think that just depends.
Yeah. What kind of management do these horses require after going through surgery? And what is your role in helping the owner through that once they come back from the hospital?
Yeah. So honestly, our role is pretty simple. It's pretty small. Just taking the line as primary care back as soon as they come home. Traditionally speaking, these horses don't come home with lots of heavy aftercare. Now, the ones that you do find yourself in a different set of circumstances are the horses that maybe require permanent tracheostomies, where they actually have to have a hole placed into their trachea because the upper airway has been trashed for one reason or another. And you can see those horses actually, if they have enough damage to their larynx, that is basically not surgically correctable, or if they have enough inflammation. So that cicatrix that I mentioned earlier, that's a pretty Southeastern specific disease. If they get enough scar tissue that happens through there, that basically the airway is no longer mobile. It's no longer dynamic. It's essentially static. You basically just like squeeze the tube on a water hose and then hope that air is getting through there. And those horses can experience such high levels of respiratory distress that we actually go for a permanent tracheostomy. And so those horses are a lot different, right? Because those horses, traditionally speaking, are going to have secondary issues just with management coming home in terms of skin management. And how do we manage this new wound? And now we have to change our feed. And let's think about all of these things that might potentially happen. The temporary trach horses are actually probably higher in terms of need from us than the permanents. But, traditionally speaking, if one's in the hospital with a temporary trach, they're probably going to stay there until that trach gets taken. At least I hope they do. Sometimes they get sent home, but from us, most of the time, it's mostly just kind of being the front line for owners to talk to you guys about, hey, this is what we're expected to see. Talk to me when performance changes, if it changes, or if we need to refer back over to whatever surgeon cut this horse, and just making sure that everything is kosher.
Right. What are some signs that a horse is experiencing a true upper airway emergency, and how do you respond to those situations?
So in my region, my favorite one to reference is a snake bite. So snake bites are something that we kind of don't really think about in horses because if they're not bit on the face, you may see some signs, but it's not necessarily that crazy. But as we know, horses are quite curious. And we live in the Southeast here. We're in the northwest portion of Florida. We see lots of crotolid intimidation. So we have a very large number of rattlesnakes that move around. I actually posted on our social media yesterday. We had a really perfect, really beautiful little rattlesnake that was outside of our truck before we were leaving the farm. And so horses are super curious and they're often apt to put their face down by one. And so when they get struck on the face, they can actually have lots of facial swelling that can truly occlude their airway. Those horses, when you see that kind of thing, if you have seen a snake, if you can find the snake bite, or if you have swelling that's going crazy, you call us immediately and you get them to us as quickly as possible, because there is a very real potentiation that we might have to put a trach in order to save your horse's life. But a lot of times, if we're just looking at the performance aspect of things, increased respiratory effort is a really, really, really big one. So rate obviously will increase, sure, but effort is one that is probably more important to me than per se the rate. When I can get exaggerated abdominal effort, whether that's just in the abdominal musculature or even in the intercostal muscle, so inside of those muscles between the ribs, that's a sign that I've really got a horse that's essentially heaving and hoeing. Also, as you've seen, they'll flare their nostrils really largely, but extending the head and the neck down to the ground is a very serious one for me. If that horse is not apt to pick their head up, there is something quite wrong, and we really need to start working on that. And it's super nice to try to give my owners something to start with, essentially. But a lot of times for me, with that particular set of circumstances, if it is very genuinely serious, I don't really care for you to do anything. I just care for you to meet me as fast as you possibly can. I want to get hands on that horse in case I need to trach it, basically.
Yeah, do you have good success with stabilizing these horses in the field? Because I know you said you're 4 hours from the nearest referral hospital, so that can be a little bit of a scary situation, I imagine.
It can be quite scary, but we actually do have pretty darn good success. So I had a really fantastic education and have had the really awesome chance to learn from some really cool people. And I'm in a region that people have not had good veterinary access for a really long time, which means that they're just happy that I'm there. But that also means that I'm sometimes willing to do things that are pretty scary, because that is the only option that's on the table. And luckily, we've been pretty darn blessed that any of the true respiratory emergencies we have been able to get a hold of pretty darn quickly. Actually, in this region in the last 2 years, we haven't had any facial snake bites. So now that I've said that, I'm going to knock on wood behind me right here. I don't have one tomorrow because, like I said, I saw a snake yesterday and I probably will have one. But we have been really, really blessed. And our owners are super understanding, even if it's a small thing like, hey, let me make sure that this horse has a patent airway, or, hey, let's pass a damn tube and throw it in the trachea if we have to, or, hey, let's, trach this horse, put a catheter in and send you and run fluids while this horse is on the trailer. That's the kind of thing that we're willing to do. And our owners are super willing to do as well.
Yeah, that's great advice. Are there any emerging techniques or diagnostics or treatments that are sort of coming up in this area that you want to discuss?
Yeah. So this one kind of deviates a little bit from upper respiratory specific treatments, and some of you guys listening may actually have utilized this. Nebulization is something that we do a lot, right? If you have a performance horse that has an airway issue, you're nebulizing. But people often nebulize things like clenbuterol, albuterol, things like that to try to, your bronchodilators to try to get some dilation to the airway. But we have actually started nebulizing alpha-2M and prostride to horses that might have inflammation, not just in the upper airway, but then also in the lower airway as well. I also have actually had friends that have had horses that have had pharyngeal traumas or laryngeal or laryngeal or tracheal traumas that have injected prostride into the upper airway to try to reduce inflammation with exceptional success. One horse that I'm thinking of in particular was actually a pretty high level FEI jumper who had gotten kicked in the trachea. They watched it happen in the pasture. And yeah, he was a bad boy. Honestly, he deserved it. He did. But he got prostride actually injected into the intratracheal rings, like just straight through it, pop right on in. And it actually really reduced his inflammation, which we measured with bronchoalveolar lavages. And it really introduced some positive results for us in terms of the level of discomfort that he was seeing. So I think it's really exciting. I think it's really interesting. There was a white paper that came out a couple years ago on using A2M in horses that maybe have allergic airway disorder, but we actually deviated from that in September of last year in some of our own, like my office managers, eventers, and started utilizing prostride nebulization and have had really fantastic success. Now, it does really tear up the cups. It does not go well for the cups. You have to replace them with some increased frequency. But the BAL scoring on these horses, the inflammation, the clinical signs that we're seeing on these guys is massively reducing. So I do think it's really, really interesting. And I think it's potentially something that a lot more practitioners should start reaching for in the future.
That's really exciting. Thank you so much, Dr. Hatcher, again, for joining us on this episode.
You're so welcome. Thanks for having me. It's been fun.
I would like to say thank you again to Dr. Hatcher for joining us, and thank you to Equithrive for supporting this episode. And of course, thank you to all of our listeners for tuning in to Disease Du Jour. If you have any questions or suggestions for the podcast, please email me at csisson@equinenetwork.com.